Thank you so much. I would like to thank Aphrodite in particular and all the organizing committee for the kind invitation to participate one more year in this nice forum. We all know that actually assessment of systolic and diastolic function of the heart is an integral part of our cardiology assessment, not only for the congenital heart disease patients, but also patients who are referred without congenital heart disease just in the outpatient cardiology clinic. So we are all familiar with the so-called conventional echocardiographic techniques. You know, the 2D imaging, the M-mode, where actually we can calculate the ventricular dimensions, we can measure and estimate ejection fraction, and we can use the pulse Doppler to assess valvular inflow and outflow, and we can use the tissue Doppler to assess myocardial velocities of the wall motion. However, we are also aware that these techniques are limited by geometric assumptions, and this might not be applicable for all the congenital heart disease population. They can only provide qualitative assessment of regional myocardial wall motion. They're often load dependent and lack reproducibility. Now, with advances in echocardiography, we have additional methods that actually we can have more accurate assessment of regional and global myocardial wall deformation. So what is speckle tracking? Speckle tracking actually is a computer software analysis which uses images which are obtained by the conventional ultrasound technique. The principle of the technique is to identify areas of the myocardium, the kernels, follow them through frame by frame through the cardiac cycle, and we can calculate parameters of motion and deformation. We measure strain as the percentage change in the length of the myocardial segment, and we have also strain rate, which is the rate of change of deformation. And we can also assess the timing of deformation. So if we want to report on the strain, the software needs a reference point in time. Usually we pick the end diastole at the beginning of the cardiac cycle. We refer to the end diastole. We have an ECG and the R wave of the ECG. If we don't, we have to select a frame just before the closure of the mitral valve. And then we have end systole, which coincides with aortic valve closure, and the current consensus is to report on the end systolic strain. Now, the technique is felt to be angle independent and less load dependent to other conventional techniques. Doesn't change. Now, moving on to children, where exactly we can apply the speckle tracking, we can measure the left ventricular strain, and in some studies they report the 6-segment method just on the 4-chamber view and the circumferential and the radial strain at the level of the papillary muscle, but of course we can report the 17 and 18-segment method by obtaining speckle tracking in the 4, 2, and the 3-chamber view. We need to have good 2D image quality, which is often easier in children compared to adults. The frame rate usually needs to be between 60 to 100 frames per second, and we need to be careful to avoid foreshortenings because actually the measurements will not be accurate. We are all aware that actually right ventricular function depends mostly on the contractility of the RV free wall and the septum, so we can do the RV longitudinal strain in the 4-chamber view. The strain distribution in the RV is less homogeneous to what is reported in the LV, so actually the values are highest in the apical segments in the outflow compared to the other parts of the RV. But we can use speckle tracking also to assess atrial function, and this is used, and actually it's an area of interest, especially in adults. Depending on the cardiac cycle, if we have ventricular systole, we can assess the reservoir function of the atrium, early ventricular diastole, the conduit function, and in the late ventricular diastole, the pumping function. So if we have here as a reference point the P wave, the peak negative strain reflects the pumping function of the atrium. The peak positive strain here is the conduit function, and the total strain gives us the reservoir function. Heart rate and age influence all the left atrial strain measurements, and we should account for that in our analysis. Additionally, we can have more information about left ventricular function by assessing the twisting and torsion. So these are actually give us the same information. They gave us the gradient, the basal to apical gradient in the rotational angle of the heart along the longitudinal axis. We know that if we see the heart from the apex, actually the basal segment, they just turn clockwise and the apex anti-clockwise. Now, where we can use the twisting and torsion, mostly in research, we can measure different parameters, as you can see in the graph. And the main thing that we feel that actually the main information that we feel that it provides, it contributes to increase LV twist to a high ejection fraction despite limited myofiber shortening. In children, we have to be careful when we report strain measurements because these vary by age. We have a number of studies, reviews, meta-analysis. This is the most recent one published in JACE 2023, that actually by using the guidelines of the American Society for the Acquisition and Analysis of Speckle Tracking has provided Z-scores by age, both for the LV, RV, and for the left atrial strain measurements, and we should refer to those. Now, we believe that actually strain analysis is accurate with speckle tracking. And the reason for that is actually that we have experimental studies using implanted ultrasonic crystals that actually demonstrate that the measurements that we obtain are accurate. The fact that we have semi-automated software for analysis is a great benefit. We need less and less training nowadays, and we can use the analysis by using any ultrasound machines, by using now vendor independent platforms. But we need to be careful not to rely completely on the automated analysis. We need to check the analysis that we don't have any tracking of out-of-plane motion of speckles, the foreshortened views, and we need to be consistent in the analysis and in the reporting, whether we track the endocardial, the myocardial, or the epicardial segments. We are all aware about ejection fraction, and usually when we discuss about systolic function of the heart, we have cutoffs for ejection fraction. So what is the relationship between ejection fraction and global longitudinal strain? This is a nice publication back in 2015 that actually demonstrates that ejection fraction is determined by both the myocardial strain and end-diastolic wall thickness. So as you can see from this graph, as end-diastolic wall thickness increases, then we have an exponential increase in ejection fraction. And if the wall thickness is thinner, actually strain is far more important. But what are actually the clinical applications, if any, of speckle tracking in pediatric population? We all know that after the trilogy of Fallot repair, our main concern in the long run is the function of the right and the left ventricle. We're concerned about the pulmonary valve regurgitation, especially in cases where we have transannular patch repair, ventricular desynchrony. And most of the times, if we want to assess right ventricular function, we rely on MRI to do so. However, MRI is great. However, it remains expensive. It's not by bedside. So we need to find another echocardiographic method that actually can provide us information and help us track these patients. Here you can see a study published in Echocardiography in 2023 that actually demonstrates in a large group of patients after the trilogy of Fallot repair, you can see a wide age range from less than 1 year up to 60 years of age, that actually from the different echocardiographic indices, the strain is the one that actually provides better correlation with MRI. So actually we should consider that. And we have a number of studies in the trilogy of Fallot patients that provide additional information using speckle tracking. So after the trilogy of Fallot repair, we can see that there is reduction in the regional RV strain. We have associated strain measurements with ventricular desynchrony and the severity of pulmonary valve regurgitation. It can give us information about ventricular interactions and can help us identify the best timing for pulmonary valve replacement. Now, we have information, unfortunately, only in adult studies that actually, by using the right ventricular strain, we can have prognostic information about adverse outcome in this group of patients. Moving now to hypoplastic left heart, we all know that the mechanics of the systemic RV are not exactly the same like the subpulmonary right ventricle. Here you can see a nice study in 76 patients with hypoplastic left heart that actually they move across the different stages of the operation. And in the red dots, you can see a comparison of what we would expect to see for the strain measurements at the same age. You will appreciate that looking just on the red dots in the controls, you can appreciate that the longitudinal strain, the tendency is to improve as we move on from the neonatal period to childhood. And the same pattern is followed for the circumferential strain. So now looking at the hypoplast, the systemic RV, so what we will see is that in the pre-Norwood state, we have good contractility, adequate strain measurement, still a little bit to the similar level compared to the controls. In the pre-Glenn state, actually there is deterioration, probably due to the loading conditions, and then there is improvement, but not as much as we would expect with the controls. What is more interesting is actually that the circumferential strain does not change at all, during the different stages, suggesting actually that this systemic RV does not behave in any way like the LV. We have information that actually strain can give us information about clinical outcomes. This is a study on 66 patients after Fontan operation, and you can see that by using the global longitudinal strain, we can predict, in a way, we can have information about the composite outcome of death or transplant in the post-Fontan patients. In the first part, using a cutoff which is quite low of -7.8, actually we can have a 50% risk of having this composite endpoint within 1 year after Fontan operation. And for the circumferential strain, a cutoff of -10, actually it can give us a prediction of 50% in the 7 years after Fontan. In another group of patients, we know that increasing afterload is not well accepted, not well tolerated by the ventricle. Here you can see a nice study published in coarctation patients after coarctation repair. So in these patients, it is interesting that after successful repair of coarctation, these patients, they didn't have hypertension, the deformation properties, they were significantly impaired compared to controls, whereas the other echocardiographic indices had no abnormalities. In this particular study, actually the degree of longitudinal strain rate impairment was correlated with age at repair and aortic stiffness. So actually there is some evidence of vascular disease in these patients which may affect the myocardium as well with increasing the afterload. And these findings are also supported by another study, more recent one, that actually demonstrates that the increased aortic stiffness in the coarctation patients actually relates to abnormalities in the strain, not also in the left ventricle, but also in the left atrial mechanics. In hypertrophic cardiomyopathy patients, we discussed a little bit about cardiomyopathies in the past. What do we use in adult studies? The left atrial strain actually is coming up as an important measure to use in order to stratify these patients for the exercise capacity. And we have similar evidence actually in children. This is a nice study published in JACE in 2021 in 78 children with HOCM, and comparison was made with a small group of healthy controls. It was interesting that actually this group was divided in two parts. So the one who had the phenotype, positive phenotype, they have shown the HOCM phenotype, and the others, the 32, they had confirmed diagnosis of hypertrophic cardiomyopathy on genotype, but no evidence of the disease as yet. So this study demonstrates that actually the issues with the functional properties and the left atrial strain actually can be seen only in the patients who had expressed the phenotype and not the genotypic one. And actually lower left atrial conduit function was associated with worse exercise capacity in the pediatric population. In pulmonary hypertension, another condition, we know that deterioration of the RV function is a bad prognostic factor for these children. And here you can see on the table the different measurements, echocardiographic measurements that you can use in order to assess RV function. But from all this, the study actually demonstrates that the RV free wall strain gives us a better prediction for the event-free survival. So having as a cutoff 14%, you can see the discrimination between the graphs for the risk of surviving for these patients with pulmonary hypertension. Now, in another field, in the oncology patients, we know that cancer patients now live for longer, but actually toxicity from the medication and cardiac toxicity is a concern. And we have emerging data, mostly in adults, that suggest that using strain might be useful in identifying early myocardial changes. I'll give you an example of this study published in Echocardiography in 2015, where you will, that actually you will demonstrate and you will appreciate that whilst ejection fraction remains the same, 54 and 53%, the strain has reduced in the middle. So actually, if we had this measurement, we could have introduced treatment rather than waiting till the ejection fraction is down to 35% or the GLS to the values that actually treatment might not be responsive, at these late stages. And we have also other recent data that demonstrate in a meta-analysis, 21 studies, 1,782 patients, mostly again here in adults, that actually the lower GLS can give us important information about the risk for toxicity. So the patients, for example, start anthracycline treatment, we are doing the strain measurements, and we can use the strain to guide us and to predict what is going to happen in the follow-up of these patients. Myocarditis, especially the last 3 years, we had quite a lot of concerns about new developments, viral, COVID, not COVID, related to myocarditis. Most these conditions we know that affects myocardial function, but how strain can help us. It's not just to diagnose the condition, but actually can give us predictive information about outcome and the risk of complications. This study, published in American Journal of Cardiology 2021, actually demonstrates that having cutoff of -11 in cases of myocarditis, actually we can prognosticate about the risk of arrhythmias and heart failure in these patients. Kawasaki disease. Now, Kawasaki disease, actually, it has increased the incidence in the last years, and actually we can see the condition probably in younger population. The diagnosis is clinical, and we assess, as the cardiologist, the cardiac and coronary involvement later on. And now there is this study published recently that actually demonstrates that if you use at the initial stage, at the acute phase, where actually you have not really made the diagnosis of Kawasaki disease, you're in between, this can help you identify and make the diagnosis and actually prognosticate for these patients. So having a cutoff of -19 in suspected Kawasaki patients actually can assist in the clinical diagnosis and give us prognostic information about more severe abnormalities in the coronary artery involvement in the follow-up. The multi-system inflammatory syndrome, we are lucky that now with the vaccination we don't see so much this condition, but actually this is one of the initial studies published from our group at the Evelina Children's Hospital that actually demonstrated that this condition had more cardiac involvement than was previously considered. And here you can see a variation, a great variety of cardiac measurements that we have done, and of course the strain measurements, which were significantly impaired at the beginning, but also they had a tendency to recover, at the discharge phase. And we have now data from the long-term COVID that actually demonstrate that by using strain, the LV and RV function of this, in this particular condition seems to improve within a period of 6 weeks, and in some cases up to 6 months. So actually, the guidelines and the guidance that we have just about exercise capacity and what we need to do if the patients, they had abnormalities with missed cardiac abnormalities, the 6-month period probably is a safe period for them to return. And it's not just in the pediatric echocardiography. Actually, speckle tracking can be applied even in fetal life. So we can assess the deformation of the left and the right ventricle, and we need to be consistent in the acquisition, in the frame rates, and we can assess the same way as in the pediatric population, the global and segmental longitudinal strain. We have information that actually this is a really nice study from Spain, from Fatima Crispy's group, that demonstrate that the growth-restricted fetuses, that we know that they have increased risk for cardiovascular disease, they have reduced strain in fetal life. And what was more important is actually, if you see this arrow here, the post-systolic shortening, so actually inefficient contraction that occurs after the closure of the aortic valve, was associated with the risk of hypertension in adolescent period. Our group and myself, we have done extensive phenotype of different stages in pregnancy, 20 weeks, 36 weeks at King's, and we have demonstrated that from the variety of the cardiac measurements that we can perform, strain is actually more sensitive to pick up early myocardial changes, not only in the severely growth-restricted ones, but also in the small for gestational age ones. And other applications in pregnancy complications like gestational diabetes. Our group has demonstrated that these babies, they have reduced global longitudinal strain in fetal life. We have associated the exposure time to diabetes and diabetes control with our measurements, but also we could see that these changes and these abnormalities track, improve, but exist during infancy. So to summarize, strain imaging has been used in clinical practice in adult echocardiography, not so in pediatrics. In pediatrics, it is mostly used as a research tool. I hope that I have convinced you that there is a variety of conditions that actually strain imaging can be applicable. It is easy to perform. Now we have more consistent results. It can give us prognostic information. So I think it is timely for us, the pediatric cardiologists, to consider the incorporation of this technique into our clinical practice. Thank you so much.